Bismillahirrahmanirrahim. Today, our topic of discussion is practical approach for managing STEMI patients in the view of latest guidelines. This is a little disclaimer that this presentation is just for the educational purposes and do not replace any personal professional judgment with any personal conflict. Outlines. We have just brief introduction to STEMI, then we will discuss some related scenarios, and there will be just some short take-home messages. So what is STEMI? A time at which the patient with ischemic symptoms is interpreted as and presenting with ACS and ST elevation. Newer ST elevation at J point in at least 2 contagious leads, like more than 2.5 mm in men less than 40 years and more than 2 millimeter in men more than 40 years, or 1.5 mm in women regardless of her age in leads V2 to V3, or 1 mm in other leads in the absence of left ventricular hypertrophy or any other bundle branch blocks. So STEMI falls in the spectrum of ACS. STEMI falls under the spectrum of ACS, which is one of the leading causes of death worldwide. Typically, there are ST elevation in ECG along with chest pain, which lasts for more than 20 minutes and is not relieving with nitrates. ECG should be done within 10 minutes of first medical contact. Okay, when to intervene, this is very important. If the patient is presenting in PCI facilitated unit, the door to balloon time should be less than 90 minutes. If you are presenting in non-PCI facilitated unit, the door to balloon time should be less than 120 minutes. If the patient is presenting in non-PCI facilitated unit and you are like you are going to go for fibrinolysis, the door to needle time should be less than 30 minutes. We are going to have some brief introduction to antiplatelets because in this webinar, we also have some postgraduates who should be knowing about how much antiplatelets to be given. So the aspirin is 300 milligram, clopidogrel is 300 to 600 milligram, prasugrel is 60 milligram loading dose, and ticagrelor is 180 milligram orally. So let's deal with some daily life scenarios because they are important and they should be discussed in this webinar because we have a lot of such patients who are arriving with diseases along with STEMI, and we have to manage them. Our first scenario, there is a 54-year-old male who is a known case of stage 2 stomach cancer. It has presented to us in emergency with complaints of chest pain from 3 hours, and ECG is showing acute anterior wall MI. He is currently on anthracyclines for 3 months, and his recent reports are showing a slight regression in the mass located in the stomach. What would be the best possible treatment you would offer to him? So, here are some recommendations for the acute coronary syndrome along with the comorbid conditions. As we have discussed, the patient is having cancer. So, what does the new guidelines in ESC 2023 say? They say that an invasive strategy is recommended in cancer patients presenting with high-risk ACS with expected survival of more than 6 months. This is class 1 indication. And a temporary interruption of cancer therapy is recommended in patients in whom cancer therapy is suspected to be the contributing cause of ACS. So, in this case, as we have said that the patient stomach mass is regressing, so we can say that he is responding to the treatment and his expected survival can be more than 6 months. So, invasive strategy is recommended. And temporary interruption is also recommended in this case. As we know, anthracyclines are notorious in causing ischemic heart disease. So, along with the discussion from oncologists, we can have some temporary interruption of cancer therapy, and if it is suspected to be the contributing cause, this is class 1. However, if a patient is having less than 6 months of expected survival time, we can go for just conservative management. For example, if in the above scenario, it was somewhat different that the patient mass is not responding to anthracyclines and his mass is growing bigger and bigger, we could have said that the patient is having less chances to survive more than 6 months. So we can have a conservative non-invasive strategy, which is clause 2A. So moving towards the next scenario, there is a 66-year-old male presented in ER with inferior wall MI and was fibrillized at a periphery. The other day, patient was referred to PCI facilitated hospital because of second-degree heart block, Morbid's type 2, with a heart rate of just 44 beats per minute. Patient was shifted to cath lab for intervention, which showed severe stenosis in proximal RCA, along with moderate diseases in the other vessels. This was implanted in RCA, but still there was second-degree Morbid's type 2 AV block and heart rate of just 36 beats per minute. Even the heart rate was decreased. And that was his 4th day of hospitalization after MI. So what should be your plan in such cases? In the light of new guidelines, ESC 2023, here are some recommendations that if the patient is having bradyarrhythmias and the sinus bradycardia with hemodynamic compromise or high degree of block without stable escape rhythm, as our patient is having just 36 beats per minute, IV positive chronotropin medications like adrenaline, vasopressin, atropine is recommended. Temporary pacing is also recommended. And urgent angiography is also class 1. As we have done the urgent angiography for for the reperfusion therapy, but unfortunately patient was not responding to the reperfusion therapy. So what should be our next plan? Our next plan should be implantation of permanent pacemaker when high degree block does not resolve within a waiting period of at least 5 days after MI. These are the new recommendations from ESC 2023 that you just wait for 5 days. If this patient was just at 4th day of hospitalization post-MI, we have fixed the artery, we have fixed the lesion, but still the patient is not responding. So then what? You just plan for permanent pacemaker also. This is now class 1. In other words, in selected patients with high degree AV block, with anterior wall MI, with failure signs, you can also plan for CRT-ND, but this was not the scenario of ours. Our scenario is basically the implantation of permanent pacemaker is recommended in when high degree block is not resolving after 5 days of MI and even after revascularization. This is class 1. Scenario number 3. A 58-year-old female with a known case of esophageal ulcer presented in ER with acute anterior wall MI. Her primary PCI was done and this was implanted. She remained well throughout her hospital stay with no complications. She came to you in OPD for follow-up after 4 months with absolutely no cardiac issue. But was complaining of epigastric pain related to her esophageal ulcer. She believed her symptoms were aggravating due to the medications she's taking for her cardiac disease. So what should be your strategy regarding her DAP duration? In our clinical practice, this is one of the most common scenarios that the patient is having esophagitis, esophageal ulcer. Sometimes they are presenting with so much esophageal pain that we have to rethink about how much DAP therapy should be tapered on. So there are some newer guidelines in ESC 2023, like there. In HBR here stands for high bleeding risk patients, and the other is de-escalation therapy. So the new ESC guidelines suggest that if the patient is at high bleeding risk, you can just continue or you can have the effect of these DAP duration for 3 to 6 months, not giving it for the full 12 months. You can have. And there is other strategy which is called DAP de-escalation strategy, that you have to omit the potent P2Y12 inhibitor to the less potent like clopidogrel. For example, if the patient is taking prasugrel or ticagrelor, you can just switch down to clopidogrel, which has got some low bleeding risk. And in such patients which are complaining of again and again stomach pain and epigastric pain, what to do with that? Can you switch down? Can you just have some lower amount of DAP duration? So the answer in these guidelines is yes. So in patients or shortening or de-escalation of antithrombotic therapy, yes. In patients who are even free for 3 to 6 months of DAP and who are not at high ischemic risk, as our patient was that she was even free from last 4 months, she was okay, she was doing her normal work. So single antiplatelet therapy should be considered. Yes, the answer is yes. Even if the patient which presented to us after 4 months of DAP therapy and she was complaining of esophageal pain, can you go for single antiplatelet therapy? The answer is yes. You can consider if she is not at high ischemic risk, right? And de-escalation of P2 vital inhibitor, that is switch from prasugrel, ticagrelor to clopidogrel, can be considered. Yes, this is 2B. So there are strategies you can apply to those patients and have the results. The next scenario, this is also a very important scenario, and this is also being dealt in especially emergencies and older individuals. There is a 70-year-old male who is a known case of atrial fibrillation and is already taking tablet rivaroxaban 20 milligram OD. He has presented to you in ER with complaints of chest pain from 1 hour. ECG is showing extensive anterior wall MI with hemodynamic compromise. You immediately plan for primary PCI. What steps would you like to take to avoid serious bleeding complications in such patients? There are again some guidelines from ESC 2023. Anticoagulant dose should be adjusted to body weight and renal function. Radial artery approach as a default vascular should be done. Aspirin is indicated, but avoid pretreatment with P2 vital inhibitors. GP2B to be used if necessary. PPI is to be given in patients with high bleeding risk, like age is 65 years, dyspepsia, GERD, helicobacter bacterial infection, chronic alcoholic use. And our patient is, of course, is on oral anticoagulant. So what you have to do, PCI can be performed. You cannot delay PCI because of his NOAC use. So PCI performed without interruption of vitamin K antagonist or NOAC. If the patient is on warfarin or vitamin K antagonist, do not administer unfractionated heparin if the INR is more than 2.5. If the patient is in NOAC, regardless of the timing of last administration of NOAC, add a low dose of parenteral anticoagulation. For example, noxaparin, 0.5 milligram per kg, or unfractionated 16 units per kg. So, our scenario was answer to our scenario is regardless of the timing of the last administration of NOAC, initiate parenteral anticoagulation. The next scenario, and this the same patient we have discussed previously in discharge. We will discharge this patient, right? What should be a major strategy regarding the role of anticoagulation in such patients? This is an important scenario. Every day, every ward, all over Pakistan. Okay. The patient with ACS and indication for anticoagulation. What is the default strategy and what strategy to be done to reduce ischemic risk? Our patient was a 70-year-old male, already taking rivaroxaban, taking the same dose, similar for ACS, similar for ML with the hemodynamic compromise, and is promptly planned urgently. Our patient is at high ischemic risk. I would like to go for such patients. I would like to go for treatment antithrombotic therapy for 1 month almost. For almost 1 month. I would like to go for the strategy to reduce ischemic risk in such patients. So I will follow 1 month triple antithrombotic therapy, then double antithrombotic therapy, including single detected and a NOAC. And then I will continue the NOAC for the rest of his life. And if she says something else, then you have to get triple antithrombotic therapy just for me. Then you will disable the single antiplatelet and NOAC for 1 month, and then you will continue the NOAC for the rest of his life. I answered the question. Let's move to the scenario number 6. This is also an important scenario in females every day. Now, a 28-year-old primigravida presented to us in ER with a history of typical chest pain, and ECG was showing STEMI. Her gestational age is 36 weeks. How would you proceed with her management, her mode of delivery, and her queries regarding further pregnancies? What is the most common mode of death in such patients? We all know that when primigravida or when the pregnant females develop STEMI, they usually have the disease called spontaneous coronary artery dissection. We all almost we all know that. But how would we manage? How would we deliver her? What should we plan regarding her further pregnancies? What is the most common cause of death in such patients? That question should be addressed, and that question should be known by each and every postgraduate, because they are the first one who are dealing with it. So, in patients with spontaneous coronary artery dissection, PCI is recommended for the patients with symptoms of ongoing myocardial ischemia, and a large area of myocardium is at risk. Intravascular imaging should be considered. This case have class 1 and class 2 indications. So, in this case, class 1 is PCI and intravascular imaging should be done. It is class 2A. Now, the rest of questions, how would we answer that? These are also guided in ESC guidelines 2023. They say that the delivery should be postponed for more than 2 weeks after the event, as at this time, patient is very high risk because the patient is already suffering from such a huge trauma. If you are again giving her such a straining position, she's going into the labor, it is very, very much obvious that she can again having the dissection, and all the bad scenario will happen again. So we would like to postpone her delivery for more than 2 weeks after the event. Mode of delivery can be vaginal, and it can be decided by the obstetrician. It is not to us that we will ask for the vaginal or we will ask for the C-section. It is for according to the sake of the obstetrician. If she wants to make her deliver vaginally or make her deliver by C-section, it's according to the up to the obstetrician. Patient usually die of ventricular arrhythmias. Further pregnancies should be discouraged in such patients because we never know that how much the risk each and every patient carry. Regarding this, the ACC journal, I would like to add some points that they considered some patients and they have collected the data of such some patients with spontaneous coronary artery dissection, and they proceeded towards further pregnancies. It was noted that many of the patients carried the pregnancy very well, but that not carried well died spontaneously. So ACC discourages the pregnancies in such patient because you never can have an idea which patient is having much risk than the other. So up to scenario number 7, a 47-year-old male presented in ER with complaints of typical exertional chest pain from 5 hours. There were dynamic ECG changes in lead 2 to lead V6, along with raised troponin levels. The patient was urgently taken to cath lab for coronary angiography and possible stenting, but it turned out to be a mild disease and LAD insert. As there was just mild disease in LAD and SIRC, the patient was reassured, that is, no test was implanted, no VMS was implanted, and he was shifted back to CCU. What is the possible answer to this scenario? How will you proceed further? These days, myocardial infarction in non-obstructive coronary arteries is a big deal. Such patients do not have any disease on the coronary angiogram or just a mild disease, which you cannot say that that disease have caused the myocardial infarction, such a huge myocardial infarction that led to raised troponin levels. So in patients with working diagnosis of MINOCA, you just go for CMR. It is class 1 now. CMR, cardiac magnetic resonance imaging. For example, if the patient have something, if the CMR tells you that the patient is having some type of disease, manage the disease of that patient according to the CMR, what the CMR is suggesting. So the final established underlying diagnosis recommended and consistent with the appropriate disease-specific guidelines, what the guidelines are suggesting, just go and manage the problem according to that guidelines. In all the patients with initial working diagnosis of MINOCA, it is recommended to follow a specific diagnostic algorithm, which I am showing you in the next slide. This is from ESC 2023 guidelines. They are suggesting the MINOCA diagnostic algorithm. We have taken the clinical history, we have done the physical examination, we have done the ECG assessment, we done through the angiographic assessment, but still we have reached nowhere. So go for CMRI, blood test, CTP, and CT brain also, right? And please guide your patient, or your disease-specific management should be according to the diagnosis based on CMR. Next, scenario number 8. A 69-year-old male presented in ER with the complaints of chest pain and shortness of breath. And he was diagnosed as a case of acute anterior wall MI. It was revealed while taking history that patient had off and on history of gastrointestinal bleed, and his HB came out to be just 6.3 milligram per deciliter, and his platelet count was just 61,000. If his coronary angiogram turns out to be normal, what would be your further plan? So the answer is there is no specific pharmacological treatment for type 2 myocardial infarction. What is type 2 myocardial infarction? Type 2 myocardial infarction is a supply demand compromise. As I have told you in the scenario, that the patient's HB was just 6.3 milligram per deciliter. So it is quite possible that her supply demand is much more than her supply. Her demand is much more than her supply. So if the oxygen demand is not being fulfilled by her supply, so she can, or he can have some pain in her chest, and he can have some myocardial necrosis even due to such small amount of hemoglobin in her blood. However, we cannot ignore coronary angiogram in such patients. We will go for coronary angiogram in such patients, because if there is some lesion, we can demonstrate that this patient have some aggravating factor also along with anemia. Okay. So what is the use of IV iron in such patient? Yes, the use of IV iron has a class 2 recommendation among patients with heart failure and anemia. Not an ischemia, but if they are saying if the patient is having heart failure, he's complaining of shortness of breath, go for IV iron, and it is class 2 recommendation in AHA guidelines. And most of the IV iron patients with heart failure have investigated ferric carboxymaltose. The management should focus on the treatment of underlying cause and control of CV risk factors. That is, you cannot ignore the CV risk factors. You should go and see that if the patient is diabetic, if the patient is hypertensive, if the patient is having hyperlipidemia, should also go its or her CV risk factors also. And you cannot just say that this is the side part issue. We are not going to suggest any other thing, but you should look at all serious and then manage the patient accordingly. But please focus on the underlying cause also. These are ESC guidelines 2023. So moving on to the next and last scenario, which is very important in today's era. This 57-year-old female presented in ER. It's also spent from last 3 years. And was immediately taken to cath lab because of her hemodynamic compromise. During coronary angiogram, we see that RCA had a tight lead proximity, along with severe stenosis in mid and distal LAD and open. How would you proceed in this case? Non-IRA management, non-related artery. So we have the scenario. This is a very common scenario, and we are dealing with like in every cath lab situation. That patient is having hemodynamic compromise, MI, and they need just open. And when this coronary angiogram, all the three vessels are all the three vessels are severe stenosis. How do you proceed in such cases? This is the answer. It is recommended to base the revascularization strategy, incorporated PCI, multivisible PCI, or tablets, whatever you're going to do, on the patient's clinical status. Clinical status, by clinical status, they are mean that the patient is hemodynamically stable. Patient is not hemodynamically stable. You have to decide that. Patient is having multiple vessel disease in ACS, presenting in cardiogenic shock. Another patient she was acute inferior wall MI along with hemodynamic compromise. So infarct-related artery, only PCI during the index procedure is recommended. This is class 1. However, stage PCI of non-IRA, non-infarct-related artery should also be considered. This is class 2A, right? But if the patient is having multivessel disease, she or he is hemodynamically stable, what you have to do, you can have complete revascularization either during the index PCI procedure, that is you are doing the PCI procedure for her STEMI, or within 45 days, you can also fix the non-infarct related arteries. You have two options in case the patient is hemodynamically stable, either fix it at the table or you can have the time for 45 days. It is recommended that the PCI of non-infarct related artery is based on angiographic severity. So this is another logarithm from ESC 2023 that if the patient is having cardiogenic shock, immediate PCI of IRA only. This is class 1. And stage complete revascularization. It doesn't mean that you can leave the revascularization. You have to do the revascularization. You plan for it. This is class 2. But if the patient is hemodynamically stable, complete revascularization is suggested during the index procedure or within 45 days. This is class 1. This was my last scenario, and I would like to share an article from the Serious Journal. This was published from CPIC Institute of Cardiology, and it shows experience and outcomes of primary PCI in a tertiary care hospital in South Punjab, Pakistan. This was an original research conducted at CPIC Multan. It was important to share, to tell you about how much South Punjab is affected from this disease and what are the rationals going on and what are the categories involved. To calculate the burden of disease, a total of 1,132 patients were included in the study. 934 were males and 198 were females. So the burden of disease in South Punjab is much more to the males. The most common age group was 40 to 65. Smoking was the most common factor. LAD was the most common artery involved. And the average balloon time was 41 minutes. STEMI-3 flow was achieved in 80% of the patients. So conclusion from the above article is that primary PCI is not only myocardium saving, but also a life-saving procedure in patients with STEMI. Less total ischemic time means less myocardial damage. We have just small take-home messages that antithrombotic therapy includes antiplatelet and anticoagulant therapy, right? So antithrombotic therapy is indicated in all STEMI patients, regardless of the management strategy. Prasugrel and ticagrelor are preferred P2Y12 inhibitors. A primary PCI should be immediately planned in patients with STEMI. Routine radial access should be used, and DES is the standard of care. In STEMI patients who are hemodynamically stable, multivessel revascularization is preferable. However, if there is hemodynamic compromise only infarct-related artery to be addressed, and the rest of vessels can be opened or can be fixed during index hospitalization or within 45 days of event. MINOCA. MINOCA now represents a significant group of patients with a ratio of 1 to 14% of the patients diagnosed as PCS, and CMR is class 1 indication in all the patients who are diagnosed as MINOCA. Older patients and adults with comorbidities should undergo the same diagnostic and treatment strategies, keeping in view the renal functions and dose adjustments. In patients with platelet count below 30,000, clopidogrel should be avoided. And in patients below 10,000, aspirin should be discouraged. So these were some take-home messages from my side, and thank you for your attention. Any questions from the panelists and from my respected participants would be highly appreciated. And I'm thankful for panelists who have taken time for attending this webinar. Thank you so much.
Thank you, Dr. Alina. Very nice and presentation. We have Dr. Harun Aziz Khan Babar Saab. There is a question: how to determine dual antiplatelet duration in patients those are having high bleeding risk as well as having high ischemic risk? Sir, Professor Harun Aziz Khan Babar Saab.
Yes, thank you very much, Imran. Actually, you have to take every patient individually, number one. Number two is that you have to differentiate between, like what we were talking about, the ACS and non-ACS patients. Because both of these patients you will come across, and you are doing the PCI procedures, either they are acute in the acute stage or either they are elective procedures. So patients who are at high bleeding risk, the first thing is that if the patient was a planned patient had a planned procedure, it was an elective angioplasty or stenting, then of course what is recommended is that you can stop dual antiplatelet therapy in 3 to 6 months' time. This is one thing in elective procedures. And if the patient had a procedure done in acute setting, in acute coronary syndrome setting, then the recommendations are to carry on the dual antiplatelet therapy up till 1 year. But especially in patients with high bleeding risk, you can, it depends upon the type of stents you are using as well. Because now what we have seen in third generation stents and fourth generation stents, the duration of dual antiplatelet therapy can be decreased. And even there are some stents in which after 1 month's time, you can stop one of the antiplatelet therapy. Usually what we can do is we can tailor it and we can stop it in 2 months' time. So like these new or zero stents, and these are new stents with a lot of I will say edge over the previous stents we were using. So in this setting of high bleeding risk, depending upon the patient, individualized patient, up till 2 months time, in 2 months time, you can stop the dual antiplatelet therapy. So this is what the recommendations are.
Thank you, and I would like to hear from Professor Dr. Tariq Abbas Saab. Question is that if the patient is in case of ST elevation and the non-infarculated artery is having CTO, then CTO should be opened or a complete revascularization should be done in that scenario. Thank you.
Thank you, Dr. Imran, and very nice presentation by Dr. Anila. I really appreciate the way she has taught us and described the various scenarios. I before that would like to add some scenario also. These are the real world scenarios. We are about to shift a patient with inferior valve MI to cath lab, and during the shifting, he told us that I am HIV positive. And that moment is very difficult for us to decide whether we should take it to the cath lab or we should deny for primary PCI and shift back to the emergency unit. What should we do? Because it is very difficult to deny also and to take it to the cath lab and causing all the areas at the risk of having a HIV positive things, and then the operator that. Anyhow, similarly, the dengue is in also, and we have a lot of patients coming in with the fever and a history of with low platelet count. We don't know at that time, and we started usually immediately the angioplasties, and after that we had a CBC, and there is a very low platelet count. This is also scenario coming to us, and recently we finished with the COVID era, and that was also very difficult time for us for the treating the patient and taking to the cath lab also. So various scenarios, excellent lecture and excellent guideline came in everywhere. They are going to decide. And about your question is that it is not a time to think about opening the CTO. Rather, I would add that if somebody is wanting that he want to continue the complete revascularization, still there is some problems going on. If he has spent a lot of time in the primary PCI, opening of the culprit vessels, he should refrain extending the procedure, especially the time at night time. And if in a primary vessel he is having a TIMI2 or TIMI less than TIMI2 flow, he should also refrain touching the other vessels also. Similarly, if he has used a dye more than 200, I would say, because in a routine procedure, if somebody is using more than 300 ml of dye, he should stage the procedure. In acute MI, we are not knowing what is the kidney function of that patient's. More than 200, I would say, is enough. If somebody is using more than 200 dye, he should not go for the PCI of the other vessels which are non-culprit and should stage for that. Similarly, the CTO vessels, it is very difficult to decide at that time whether this MI is causing by the culprit vessel or the CTO vessel supplying the other vessels. And patient can go into the shock during the procedure, because when you're handling that vessel, which is supplied by the other vessels, on which is also diseased, so it is very difficult. A lot of myocardium got jeopardized. So it is very difficult. In acute setting, the only aim is to gain the flow in infarculated artery. You open up infarct. Sometimes the scenario that you cannot fix the vessels also, even because there's a straightforward case of cabbage. At that time also, you are aiming that you have to maintain the flow in an infarculated artery. Later on, in 24 hours or 48 hours, you take the patient again to the cath lab, check it up, and if patient is clear-cut cabbage patients, then stabilize the patient, send the patient for cabbage. So various scenarios, they are coming daily basis. We are doing 10 to 15 primary PCIs, and every PCI has a different PCI and different scenario. Thank you very much, Imran.
Sir.
Yes.
So I'm now.
Yes,
Yes,
Javed,
sir.
let me add one more thing. It was an excellent presentation, of course, by Dr. Alina. And Professor Tariq Abbas has, mashallah, told us a lot of caveats and lot of tips about the primaries and other workup of angioplasty. In these scenarios which he presented, there was one what we were talking about was that should we fix the culprit vessel only, or should we also fix other vessels which are diseased and which are flow limiting. So there are a lot of studies on this. Like, of course, one thing is agreed that if the patient is hemodynamically unstable or the patient is in shock, you should go for the infarct-related artery. But if the patient is stable, different studies have shown that especially if you have got the availability of FFR, and if you use the FFR, it is slightly more superior to open the other vessels as well. So at the same time, you can fix the other vessels provided the patient is stable, and you can give the benefit to the patient, and of course provided you limit the contrast at the same time, because we have got a very efficient formula of using the contrast, which is by the weight you derive. According to the weight of the patient, this is what the contrast is being used, and also according to the kidney renal function. So, and if the patient is also is well hydrated, all these things matter. So I think we should look at the patient individually, and of course we should also look at the background studies which have been carried out. Thank you.
Thank you, sir. Our next, my question is to our next panelist, Dr. Kamran Babar Sahab. The question is, what should be the route in case ST elevation MI? Whether we should take the transradial route, transfemoral route, or what's your opinion and what's your experience in case of ST elevation MI? Dr. Kamran Babar Sahab, please. I think Kamran Babar Sahab has left. I have seen in the attendees, General Suhail Aziz Sahab. I would like to hear from him about the route, what should be the route, and what strategies should one take to avoid no flow in case of ST elevation MI. Professor Suhail Aziz Sahab, General Suhail Aziz Sahab, please. So I think there is some problem. I will ask from the Professor Dr. Harun Aziz Sahab.
अस्सलामुअलैकुम।
What's your Islam?
हाँ नहीं, बस असल में पहले मुझे इतना ठंडी रखा हुआ था, तो अभी पैनलिस्ट में ऐड किया है. I think it was an excellent presentation by Dr. Alina. I really enjoyed it, the case based presentation, जैसे कि Dr. तारिक अब्बास ने भी हाईलाइट किया. डॉक्टर इमरान, जो आपका क्वेश्चन है, इसमें डिफॉल्ट वी ऑलवेज गो फॉर द रेडियल. डिक्रीज चांसेस ऑफ कॉम्प्लिकेशंस, डिक्रीज चांसेस ऑफ ब्लीडिंग. लेकिन द ओनली ऑप्शन मैं फेमरल तब करता हूं जब कभी आपकी रेडियल की पल्स कोई अच्छी ना आ रही हो, पेशेंट हीमोडायनामिकली कॉम्प्रोमाइज हो, तो उसमें फिर हम टाइम वेस्ट करने की बजाय फेमरल राउट से करके फौरी तौर पे रिवास्कुलराइज करने के लिए कोशिश करते हैं. लेकिन मोस्टली चूंकि हमारे पास इंफॉर्मेशन नहीं होती पेशेंट का प्लेटलेट्स की, सीबीसी की, ब्लीडिंग डायथीसिस की, तो रेडियल हैज बीन फाउंड टू बी मोस्ट सेफेस्ट. डेटा में इवन मोर्टेलिटी बेनिफिट भी जो है वो शो किया गया है by using radial, and preferably I think all of our centers are mashallah using radial as their predominant access.
जी इमरान, ये राइट, रेडियल के कॉम्प्लिकेशन रेट बहुत कम है, और ऑफ कोर्स इट इज मोर हैंडी विद लेस कॉम्प्लिकेशन रेट, and now the people have become so much expert in this, because for the last I think 15 years 20 years radial is being used excessively. So हमारे जो ट्रेनीज हैं, हम लोग खुद हैं, हमारे colleagues हैं, उन्होंने radial की know how बहुत अच्छी आ गई है, and it is a safe procedure.
Right, sir. Right. I would like, I am having a question for Dr. Tariq Abbas sir. The question is that if the patient is having anterior MI and is having high clot burden, and where even the flow is not maintained, what should be the other strategies? Professor Dr. Tariq Abbas sir, please. Dr. Kamran, if you want to give the answer of this question.
So basically, if you're not having a
clot.
good flow, Hanji, I mean, the thing is that we should be able to see the distal vessel. And once you have crossed it with the wire, you have ballooned your way, and you can see a distal flow, and myocardial blush needs to be there before you can start thinking about stenting the area. Many a times there might be a underlying dissection. So microcatheter कई दफा एडवांस करके देखा जाता है, डिस्टल आप इंजेक्ट करके देखते हैं कि आपका डिस्टल फ्लो तक जा रहा है या नहीं जा रहा. We do know that when there is a late presentation, कई दफा the clot organizes and kind of fills the whole vessel. और जब तक आप उनको प्रॉपर थ्रोम्बेक्टमी ना करें, आप क्लॉट बर्डन ना रिड्यूस करें, पीसीआई करने से आप कुछ बेहतर अचीव नहीं कर पाते पेशेंट के लिए. So I think the important thing is that whenever you are evaluating your patients, आपने एक 100% artery देखी, आपने उसको इतना ओपन कर दिया कि उसमें से फ्लो आना शुरू हो गया, तो स्टेंट करने में जल्दी नहीं करनी चाहिए. पहले आपको एक आर्टरी को एनालाइज करना चाहिए, डिस्टल बेड का मायोकार्डियल ब्लश एस्टेब्लिश करना चाहिए. उसके बाद आप स्टेंटिंग का डिस्टेंस कि कितना आपने एरिया स्टेंट करना है, कितने क्लॉट को एंट्रैप करना है. क्योंकि कई दफा होता है कि क्लॉट इतना ज्यादा होता है कि व्हेन यू डू stenting of that segment and you do repeated post dilatations, तो shower होके बहुत सारे no reflow कर देते हैं. तो कई दफा आपको एडेनोसिन वगैरह देके और उस डिस्टल मायोकार्डियम को ब्लश रिस्टोर करना पड़ता है, जिसमें कि एपिनेफ्रीन कई दफा जो होती है इंट्राकॉर्नरी, वो भी बहुत इंस्ट्रूमेंटल होती है. So these are a couple of tools that you can utilize, and you can improve the flow of your patient.
And of course, you should also remember glycoprotein 2B3A inhibitors, especially in people with high clot burden.
Absolutely true.
Right, sir. I have a question for Dr. Alina. The question is that on what basis 3 to 6 months DAPT dual antiplatelet duration is advised? Dr. Alina Ajmal, please.
Yes, sir. Sir, there is a trial done called TICO trial. It was done with ticagrelor while having aspirin for first 3 months, and then just continue with the P2Y12 inhibitor in patient with STEMI, and also the patient was implanted with the DES. And the patient was having high bleeding risk along with some esophageal symptoms in such patient. So TICO trial was done with aspirin for first 3 months along with ticagrelor, and then they just continue the ticagrelor for the rest of the 9 months. So this is the trial which was also suggested in the ESC 2023 guidelines.
Okay, thank you. Professor Harun Saab, can you tell us about your strategy in patients with ST elevation MI regarding antiplatelet therapy? Would you go with the ticagrelor or clopidogrel? What's your strategy in patients with ST elevation MI?
Very important question you have asked, a very important one. Especially still, in our setup, most of us are using clopidogrel. But all the guidelines show that ticagrelor or prasugrel, they are both superior to clopidogrel, especially in the setting of acute coronary syndrome. So what I am now doing is that patients who come to me with ACS, I load them with ticagrelor. So ticagrelor is the indication now, of course, along with aspirin. But this is what is being recommended.
Okay. I would like to ask from Professor
But
Dr.
we are using over here Tegidrol first for first month. Usually जो हम यहाँ पे कर रहे हैं, हम ये करते हैं कि ना Tegidrol जो है ना पहला महीना इस्तेमाल करते हैं. After 1 month we switch to clopidogrel.
That can be a safe
And how long-
strategy in case of bleeding, if you are worried about the high bleeding risk. But ticagrelor, you can carry it for a longer duration as well. But for patients who are at, I think that there has been a lot of studies comparing ticagrelor and clopidogrel according to the bleeding risk as well.
There is another question, Dr. Kamran Baba. In guidelines, there is recommended that if the patient is being thrombolized for acute MI and then they shifted to the centers, and if the patient should be shifted to the center where revascularization facilities are available, and then the patient should undergo for angiography and revascularization within 3 to 24 hours. What do you think regarding in our setups? Should we go for this strategy, or should we make our strategy, as there is a lot of burden on our cath labs?
I think the primary centers, जो कि माशाल्लाह बड़े centers हमारे cardiology centers हैं तमाम बड़े शहरों में, I think the primary PCI is way to go. लेकिन अगर कभी THQ, DHQ में patient ऐसे present करता है तो उसको streptokinase लगा के shift किया जा सकता है. कई दफ़ा पेशेंट हमारी प्राइवेट सेटिंग में भी आते हैं और उनको हम जब प्राइमरी पीसीआई और स्ट्रेप्टोकाइनेज का कंपैरिजन फाइनेंशियल इकोनॉमिक बर्डन के लिहाज से बताते हैं तो दे चूज कीजिए भी एसके लगा दें और पेशेंट स्टेबलाइज होगा तो उसमें हम उनको जरूर रेस्क्यू पीसीआई की तरफ गाइड करते हैं कि दे माइट नीड अ रेस्क्यू पीसीआई इफ द पेशेंट डज नॉट इंप्रूव देयर सिम्पटम्स और इफ द एसटी एलिवेशंस डोंट गेट बेटर. और उसमें ड्यूरेशन भी इंपॉर्टेंट है कि अगर पेशेंट हैज प्रेजेंटेड विद इन 1 hour ऑफ देयर चेस्ट पेन, then the thrombolysis is much more effective. But if they are late presenters more than 3 hours, then primary PCI is way to go. लेकिन मेरा ख्याल है कि एज ए रूटीन स्ट्रेटजी अगर आप पेशेंट्स को एसके के बाद आगे करेंगे तो ब्लीडिंग रिस्क बहुत बढ़ जाता है. नॉर्मली ऐसे पेशेंट्स को हम नेक्स्ट डे लिस्ट पे डाल के कर देते होते हैं, लेकिन अगर रेस्क्यू पीसीआई है तो हमने 3 hours के बाद भी 2 hours के बाद भी किया हुआ है और उसमें रेडियल अप्रोच करके हम पेशेंट को रिवैस्कुलराइज कर देते होते हैं.
There is another question for Dr. Alina, and they have asked, is there any trial on multi-vessel PCI on which all guidelines are based? Dr. Alina Ajmal.
There are multiple, thank you for the question, sir. There are multiple trials done on this subject, but the most favorite and the most common trial was culprit shock trial. It suggested that the multi-vessel PCI in patient with hemodynamic compromise is not suitable for infarct-related artery. Just the infarct-related artery should be addressed. The culprit shock trial, it is the most important trial which upon all which the ESC guidelines 2023 have been based. So there are also other trials, but according to the subject and according to the article which have written in the guidelines, they have mostly mentioned the culprit shock trial.
Thank you. Dr. General Suhail Aziz is also with us. I would also like to hear from his views regarding the presentation, and if there is any addition, most welcome.
Thank you very much. It's so nice to see all these worthy panelists, and my greetings to everybody, especially Babar Saab and Zubair Akram and yourself, sir. And I think Dr. Alina gave a very excellent summary, and the way she presented in the question format and sort out the answers based on guidelines, that is the way to go. We go through these discussions every day, that for our society it's like this, it's our society it's like this, but our knowledge base should be what the guidelines are. We may not able to be affording to do those things, but our action should be based, of course, on what we can afford. For exam, we all have to prepare for the exam and know exactly what the trials show and what the different trials have shown. About the real tricky bit to me is the streptokinase and what happens if you give streptokinase, the patient presents late. Dr. Vijat Lodi gave a very excellent lecture in the Park Live on this, and you ask everybody all over the world, and they all talk of okay, if you're late, then thrombolize and cath later. So everybody finds an excuse to do a cath later. Regarding this case, somebody's here with an acute MI, and this is not a PCI center. If you are within 2 hours driving distance of a PCI-enabled center, it is better to shift him to a PCI center, which is 2 hours away, and have a primary PCI. That will give a better result than thrombolysis followed by shifting like the drip and ship. But we must realize that VT is a big killer, and about 40% people die before they reach hospital. So when we shift, we tend to have ambulances which are just a driver and a stretcher and maybe an oxygen. So we need to have proper shifting. So for us, the situation becomes a bit tricky that people come from far off distances. They come and travel like 8 hours, 6 hours. They get to the hospital. It'll take time for them to be seen by somebody who's going to do this. Sometime, in our society now, this is not for the exam, but there's some practical point of view that people who take 6 to 8 hours to get to the hospital, they have to come. If they come at night, there's some safety issues. There's some nakabandi, some writing or something. So traffic jams. So I think heart disease should not be delayed in this evaluation. It should be taken all the way as much as is appropriate possible. If there's a cost deficiency, we should accept that. But if you ask anybody from anywhere in the world, they would all say, okay, the thrombolized cath then the next day. We talk about academics, and even the big lectures are talking about academics, but in practice, all of them end up with a cath. And there's not a bad idea in the sense that there was a study, the LIFT trial, where people who had successful thrombolysis and who had no evidence of ischemia and living a wonderful life, and as a trial they were cathed, and 15% had severe surgical disease. So our estimation is always an approximation, and the reality is that if we do not cath these people, we would miss 15% of strong surgical indications for after post thrombolysis. So that's what I thought I'd like to share.
Thank you very much. Thank you very much, General Sir, for your valuable comments. The time is short, and I would like to have the concluding remarks from Professor Dr. Harun Aziz Khan Babar Sahab.
Thank you very much, Imran. It was a very nice, comprehensive presentation by Dr. Alina. And of course, she went through a lot of different scenarios, lifetime scenarios, and she covered a lot of topics related to ST segment elevation MI. And our worthy panelists also, mashallah, they contributed very well to the different aspects of ST segment elevation MI. One thing which I will try to just give a message or just brief it up, that patients who present with acute ST segment elevation MI, 50% of them may not be able to come to the hospital. So it is very important that we should generally create an awareness in people that if somebody gets a chest pain, at least he should have aspirin at the same time. Or if somebody has chest pain, then he should not waste time, or the people should not waste time keeping him at home or away. They should immediately bring him to the emergency of the nearest hospital, because that will save him. The patient may die of VT and related problems during that period if we have wasted that time. The sooner the patient arrives in the ER, the sooner he can be dealt with either with fibrinolysis or, depending upon the circumstances, or either with primary PCI. So I think we should ask again and again and knock the door that the awareness is the key to success, and people should recognize that the chest pain may be an MI, and they should not take it lightly. And of course, if we work on this, I think many lives can be saved. Thank you.
Thank you, sir. I would also like to hear from the Professor Dr. Tariq Abbas sir regarding his inputs about this lecture, and if he can want to add anything else.
Thank you very much. One thing is very important, and that we now started knowing our own data also. And the few things are presented particularly also, that we are now finished, I think, more than 600 primary studies in last year. And the huge data we are gathering, and a very alarming situation is that very younger population and poor populations, they are coming for extensive MIs. And regarding the shifting, we are also having some dip and shift mechanism from various districts, but it is not working like this. Okay, in time they are reaching, and we are having a lot of problem to tackle these patients who have MIs, and somewhere they got SK in Laya or Muzaffargarh or somewhere else. And then when they came to us, they are in very bad shape. It's very difficult. We even with thrombolyzed, recanalize that vessels also, they are still in failure and prolonged hospital stays there. The very important thing is that the earlier you shift the patient to primary PCS centers, and the earlier you take the patient to the cath lab, you can save the myocardium, and you can tackle these patients betterly. And we are amazed that when we do the echo after 3 months down the lane, we have done last year, and nobody can say this patient has an MI. Completely normalized the left ventricular function in anterior wall and inferior wall MI, and this is a lot of gain to us also. Thank you very much, Imran. Having a very good this sessions, a lot of information and a lot of discussions and wisdoms talk by Dr. Professor Haroon, Professor Suhail Aziz Saab, and of course Kamran Babar, and Dr. Hashmi is also with us. Thank you very much.
Thank you very much, everyone.
Thank you.
Professor
Thank you,
Tariq,
everyone. I'm so grateful for giving the opportunity.
concluding. Professor Kashipati Hashmi sir, can you hear me?
I think I have to congratulate Pakistan Cardiology Society for starting this wonderful web series and rating in every big cities, and you have by turn every month different city and different speaker. A very excellent presentation by Dr. Alina and very comprehensive review of this very important topic. And the old saying, the time is myocardium. Time is important. तो ये जो ना आज का अहम लेसन भी है और टेक होम मैसेज भी है.
Sir, thank you very much. I am really thankful to all the worthy panelists, Professor Harun Aziz Babar Saab, Professor Kashipati Hashmi Saab, Professor Tariq Abbas Saab, Dr. Kamran Babar Saab, Suhail Aziz Saab, and all the audience. I am really thankful to High Noon as well for this webinar. Thank you all. Allah bless you all. Take care.
Thank you.